All right, Matt, here we are. Another AMA Ask Matt Anything. So we got a lot of submissions from both, Optispan Podcast Gmail, as well as YouTube comments.
All right, cool. I'm looking forward to it. I think we're going to be getting a lot more comments. We got some interesting content coming out. I think the video where we talk about my Radfest experience just came out today. So I have a feeling we're going to get some interesting responses to that one as well. But anyways, let's dive into the questions that you have come up with, and we'll see where we land.
Yeah, so my first one's from me, and it's what's up with that cool water bottle?
Yeah, this is so this is a water bottle that the folks at the Longevity Biotech Foundation sent me. So I'm on the interventions testing program steering committee, and we met recently, and it was a day or two after that, Rich Miller sent a picture of this water bottle that one of his students had given him. And I immediately was like, ooh, I need one of those. So I went to the LBF website, which we'll put in the show description, and asked them. I couldn't find it there because they have a store, and I couldn't find it there. So I emailed the folks at LBF and sent them the picture that Rich had sent and said, where can I get this? I really want one. And Nastia there was nice enough to send this to me along with a black lab coat, which maybe I'll wear at some point. It's a little bit too big for me. Tammy says the lab coat makes me look like Emperor Palpatine. So
you should have worn it.
Well, we'll save it for Halloween. But anyways, this is very cool. It's got all of the ITP hits from the lifespan studies in mice. So we've got acarbose, norhdihydroguaric acid, meclizine, canagliflozin, captopril, aspirin, 17-alpha estradiol, 16-hydroxyestriol, glycine, and of course, our very favorite vitamin R, rapamycin. Yeah. So all the structures are there. And I understand that the LBF folks may add this back to the store. So if you have water bottle envy, you can check out their website and maybe they can hook you up. I also want to mention they've got their 7th cohort starting. So you can go to their website, www.longbiofellowship.org, and check it out.
Cool. Should I even ask you which one's your favorite, or do we all know?
Well, I mean, it's hard to pick. I like a lot of them, actually. Obviously, rapamycin is near and dear to my heart, but I'm a big fan of 17-alpha estradiol, canagliflozin. Actually, I don't know if I've talked about this on the podcast. I actually have recently started taking an SGLT2 inhibitor. I'm actually taking empagliflozin, not canagliflozin, but I actually think there's a lot of promise with several of these compounds.
A future episode.
Yeah.
All right, so first question. So we do have a number about testosterone. So the first one is, Matt, since your main problem was low free T and high SHBG, why not address it first through medications such as low-dose Proviron?
Right. Okay. So so this is from the episode where I talked about starting testosterone therapy. So I don't have any personal experience with Proviron, so this is all coming from that perspective. So this is a anabolic synthetic steroid, also goes by the name Mesterolone. It's an oral derivative of DHT, and I think one of the potential benefits of Proviron is it doesn't get aromatized to estrogen. So you don't necessarily have the things like water retention and some of the other estrogenic effects. It certainly can be effective at reducing SHBG. It doesn't directly raise testosterone because it's a synthetic, right? And so there's some pros and cons to that. It can, if it's successful at reducing the sex hormone binding globulin, that can lead to an increase in free testosterone without supplementing with testosterone. So that would be the main upside. So first thing is, I think I talked about it in the episode, I did try several things to lower SHBG. I didn't try any synthetic steroids, but things like, dietary changes, exercise, boron supplementation, none of those worked. This might have. I didn't really consider this therapeutic route when I made the decision that I was going to start taking a steroid. I figured that going right to testosterone made the most sense in my case. I think the reasons why I would still make that decision today are, even though Proviron is not thought to be hepatotoxic or cause liver damage, it is metabolized by the liver. And I think we know, there's a long history of these synthetic steroids causing liver problems, right? It's an oral delivery route. So I'd be still concerned about that, especially in the long term. I don't think there's a lot of long-term data on the use of this molecule. And so given that testosterone is, much more commonly used and we have a lot more data, I just felt like it made sense to go directly to testosterone.
Okay, yeah, it makes sense. When I was in college with oral, they said it goes through your liver twice, where injectable bypasses your liver.
So
Total bro science. I was wondering.
yeah. So I mean, definitely the oral steroids are going to be metabolized by your liver, and so that's why many of them do cause liver toxicity. The oral form of testosterone that I started with, which I talked about in the episode, so we don't need to go into that, Jitenzo, has been formulated to bypass that first pass liver metabolism. So that is the plus side to that version of the oral testosterone. I still had side effects from that, which is why I didn't stick with it and went to the injectables.
Okay, so there's injectable, there's oral, and then this user asked why no discussion around the gel form.
Yeah, I mean, I thought about it, but I didn't think about it for very long. So the reason why I felt like that wasn't a direction I wanted to go. So this is a gel form that a cream you can put on your skin, right? And it gets absorbed through the skin. I think that works better for women than men because women typically need a lower dose of testosterone. And, again, just because of the stupidity of our healthcare system and the way it operates, there is no FDA approved injectable dose for women.
Wow.
It's ridiculous. Anyways, so I think the cream works better for women than for men typically. I didn't want to go down that road. I mean, and again, I haven't tried it, so this is my perception. It seems messy, like the idea of having to put this testosterone cream on every day. Also kind of seems like a lot of work, whereas you can either just take a pill or you can do the injection. The dosing is pretty variable. So I mean, if you're injecting a known amount, you know exactly how much you're getting. And I personally enjoy sleeping with my wife, and I didn't want to contaminate her with having testosterone all over my skin that's going to get on the blankets and, and potentially get into her system. So for me, it was sort of a non-starter for that reason, primarily. I didn't want to, accidentally be delivering testosterone to my wife.
Yep, I've seen it happen.
Have you?
Yeah. All right. Any doses that worked well for you of testosterone?
Yeah. So I mentioned it on the podcast, but I'm happy to talk about what I'm doing now. So as I alluded to a few minutes ago, I started with the Jitenzo, the oral, and that worked in the sense that it alleviated the symptoms that I was experiencing, but I had lots of side effects, and the most notable to me was major water retention and a lot of oily skin and stuff like that. So I switched to the injectable. So right now, what I've been taking the entire time since I switched to the injectable is testosterone cypionate. It's got anastrozole in it as well. So the testosterone is at 200 mg per mil. The anastrozole is at half a mg per mil, and I use 0.3 milliliters 2 times a week. And it works great.
Great. Do you inject yourself?
Yeah.
What about injection site? Do you alter shoulder?
I always do the butt. And I don't do IM. So you don't need to do IM. Again, it might say that it has to be intramuscular on the vial, but it doesn't matter. You can do subcutaneous. So I know some people like to do it in the abdominal fat. I just real easy. I mean, again, I think I talked about this on the episode. I hesitated for a long time. I had a little bit of needle phobia. I was like, I don't really want to do that. Not a big deal at all.
Yeah. Yeah. So, when I did steroids in college, we were doing 500, and then we were doing twice a week, glute, shoulder, alternating. But yeah, great. So it looks like yours expires August 17th. So make sure you use it up by then. All right. So this is what you're using here?
Yeah. So if people are, I mean, again, I'm not going to do this sort of YouTube video demonstration of me injecting myself in my butt, but I will take people through sort of like the basics. It's not a big deal. So you want to really what you need, you're going to get your testosterone prescription. It's going to come in a little vial, right? And then you're going to need some alcohol wipes. You're going to need a syringe, and I use a 1 milliliter syringe because I'm doing 0.3 milliliters for each injection. You're going to need a larger needle to draw the testosterone out of the vial. So I use an 18 gauge, and you're going to need an injection needle. So I use a 25 gauge. So it's a little bit bigger than an insulin needle. And basically you've got your 18 gauge needle on the syringe. You wipe off the top of the vial to sterilize it. You draw up the volume, so 0.3 mils in this case, and it should have a little lock on it, a locking mechanism that you can twist off the 18 gauge. You put on the 25 gauge, and then you wipe your skin with a sterile wipe and inject.
Okay. So how many milligrams again? And you might have said it already. Is 0.3 mils?
0.3 mils of a 200 mg per mil solution.
Okay.
So that's 66 mgs per injection, or 120 a week.
120 a week. Perfect. Okay. Okay, so next question. Testosterone for women under chronic stress or restrictive dieting? Question marks. Kind of wondering about.
Right. So, I mean, again, first thing to say, I'll probably say this multiple times today, not medical advice. This should always be done under consultation with your physician because everybody is different, right? So a few general thoughts though. Number one is whether you're a woman or a man, but in this case, it asks about a woman who is experiencing chronic stress and potentially doing restrictive dieting. So what's causing the chronic stress, first of all, right? Fix that if you can. Chronic stress certainly can impact hormones, broadly speaking. DHEA, estrogen, progesterone can all be impacted, and testosterone, by chronic stress. Likewise, those hormones will all be impacted by caloric restriction. So it doesn't say exactly what sort of restrictive dieting. I'm going to assume we're talking about some sort of caloric restriction or use of a GLP-1 agonist for weight loss. Again, if you are in a caloric deficit, it is very likely that your hormones will be impacted. So all of this is to say, measure, right? If you're experiencing chronic stress or you're caloric restricting or you're not, you want to measure all of your hormones regularly anytime you're on hormone therapy, man or woman, right? So that you know where you're at and you can adjust the hormone therapy, or your doctor can adjust the hormone therapy appropriately. I think in the case of a woman who is in caloric deficit, so again, either caloric restriction, dieting, or GLP-1 agonist, testosterone in that context can actually be quite beneficial because it can help preserve muscle mass. Always important to also be doing resistance training. But you need to measure all of the hormones to make sure that you're not unbalanced, taking too much testosterone or not taking enough testosterone. So again, in my view, not medical advice, testosterone should always be considered as part of overall hormone replacement therapy for women. And in many cases can be quite beneficial for body composition, metabolic health, libido, mood, energy, all of the same effects that it has in men on testosterone therapy.
All right, thank you. Next question. Is clinical rapamycin in your 30s evidence-based?
Well, it's not evidence-based in the sense that we have a lot of data on people taking rapamycin in their 30s, right? So I think maybe the better question to ask is there a rationale for somebody to take rapamycin, cycle rapamycin in their 30s? Obviously, again, it's going to depend on the specific individual situation. So personally, I think the risk of cycling rapamycin, let's just say you do a 3-month cycle once a year, I think the risk is pretty low. Obviously, we can't know for sure what the sort of multi-decade risk looks like there because nobody's ever done it. As far as I know, nobody has ever cycled rapamycin for 30, 40, or 50 years, which hopefully if you're starting in your 30s, you're going to be doing it for much longer than that if you keep doing it. So the real answer is we don't know. But I think there's no reason to think that a once-a-year cycle of rapamycin is going to be very risky. Why might you want to do that? So, if you believe that rapamycin is going to slow aging, that would be one rationale. I personally don't think that's a great rationale for starting in your 30s. But if you have an autoimmune disease, chronic fatigue syndrome, if you're an ApoE4 carrier or homozygote, so you're at risk for dementia, if you have long COVID, those are all reasons why I think you might want to try rapamycin. If you have Lyme disease, this is getting more speculative. You might want to try rapamycin. If you've had a severe traumatic brain injury, also quite speculative, but I think there's a reason there where you might want to try rapamycin. So it's going to depend on the individual's situation and if there's a rationale, and this is, again, obviously in my opinion, for them to try rapamycin. I think for people where they may get some benefit or some relief from whatever condition they're suffering from, if there's reason to think rapamycin might help, there's very little downside to giving it a try.
With what you know now, would you go back and take it in your 30s? Do you check any of these boxes? Or
in my 30s, no, I did not check any of these boxes. And I don't, it's a good question. I don't know. Probably not, but I don't know for sure. I think unless I was in that situation, I would have to think about it. But there's other stuff I could have been doing in my 30s that would have been a much bigger lever to pull than
lower hanging
rapamycin.
fruit.
Yeah.
So should I stop rapamycin during an acute respiratory infection?
Okay. Not medical advice. My personal opinion is if it's bacterial, definitely. If it's viral, I wouldn't stop.
Long-time viewer here, and I have been taking rapamycin for a year at 8 milligrams per week. I know you did a survey of side effects, but I'm guessing CBC and lipid panels were not done before and after. There are side effects that I do not think that have been addressed. My lipids jumped from a normal 180 to 220 after 8 months, and my white blood cells have been steadily dropping. Not dangerously low, but 2.7 is below normal. The hyperglycemia effect is well known, as well as lower white blood cell counts, which is normal for immune suppression in transplants. I know you do a personal 12-week on-off protocol, which I plan to follow. My lipids return to normal after 6 weeks, but white blood cell count remains low.
Okay. So there's a few things to unpack there. Again, this is always going to be individual. So this person said they're taking 8 mgs per week. That might be too high for them. Without measuring, you're not going to necessarily know what your rapamycin levels were, but it might be the case that at 4 mgs per week, they wouldn't see these changes in lipids or white blood cell counts. I think it's also worth saying that, while at the individual level, it's certainly possible rapamycin causes these effects, the studies that have looked in people using rapamycin off-label don't tend to show, at least at the population level, changes in lipids or blood glucose or CBC chem. So while it could happen at an individual level, the data we have suggests it does not happen at the population level. For example, there was a recent study that we highlighted on the podcast that looked at patients with chronic fatigue syndrome who had been prescribed rapamycin at, I think it was 6 milligrams once a week. They looked at blood glucose and lipids and A1C and saw no change. And then, if I'm remembering correctly, I believe in Joan Manick's 2014 paper where they looked at everolimus, which is a derivative of rapamycin, at 5 milligrams once a week. They did not see any effects on LDL or triglycerides or blood glucose. So, yes, it could happen in some people. And if it does, you might want to back off on the dose. The other thing I would ask is, why are you taking it? If you see, changes in biomarkers that you interpret as suboptimal, ask the question, what does the risk reward look like for you? Why are you taking it? Is there a compelling reason to continue? Do you have any of those conditions we just talked about, right? Autoimmune, long COVID, chronic fatigue syndrome. You could try a lower dose. You could try measuring rapamycin at, 2, 8, 24 hours, see if you are a slow metabolizer. I think those are all things that you could think about doing. But again, it's going to depend very much on the individual.
Should more people consider cycling? Sounds like this person's been on it for a year.
Again, what I can say is I personally have done that and have experienced effects that I attribute to the rapamycin that I would consider beneficial. The longevity data, if you're doing it for longevity effects, the data from animal models is better for continuous dosing. You get smaller effects, seemingly, from cycling rapamycin. So it depends a little bit on why you're doing it and what your individual risk-reward threshold is.
All right, great. So, Matt, how do I standardize blood testing when taking 50-plus compounds?
Don't take 50-plus compounds would be my answer. Yeah. Again, I've talked about this before. I see no compelling reason to be taking more than 5 supplements, right? If you're taking 50-plus things, in my view, you're probably having an overall negative impact on your health. But if you really want to do that, I don't think it would change my approach to biomarker assessment, right? I think you still want to measure the same core set of biomarkers. My preference obviously is the blood test that we use here at Optispan. We talked a lot about this in the recent episode with our clinical director, Dr. Nikki Byrne, as well as Dr. Kevin White. So I don't think I would change what I measure, but you have to realize you can't draw any conclusions about a particular supplement or medication if you're doing that many different things. Yeah. So just got to live with it.
Yeah, you have to do a lot of blood work and add one at a time, I'm assuming. Like, is there a way to ramp up to that, or not feasible?
I mean, you could, but even then, let's say you were to do that, right? You start taking one thing, you wait 3 months, you measure your blood work, you start taking another thing. You could get an indication as to whether that most recent thing you added changed your biomarkers, but you still wouldn't know if it was that thing alone that did it or that thing interacting with everything else that you're taking at that point. So, I think given kind of where we're at in the space right now and our limited information around combinatorial interactions, the kind of the best we can do is create the gold standard biomarker set for health and try to evaluate where each individual is at based on that, and then take targeted actionable steps to move the biomarkers that we see are suboptimal into the optimal range.
Great, yeah, makes sense. Bone-focused DEXA versus full body composition DEXA. I get a DEXA scan every couple of years for bones, osteopenia. Is that the same scan that shows full body composition?
Okay, right. I mean, this is confusing. So, the answer is kind of. So, the same machine, DEXA machine, can be used for both whole body composition and bone density from a clinical diagnostic perspective, usually with different software. But in general, when you go to a DEXA facility, they are either going to do a full body scan or a bone density scan that can be used to diagnose either osteopenia or osteoporosis. So the primary differences are with the full body scan, what you're going to get is bone density, positional information. So by that, I mean arms, torso, legs, head, positional information for bone density, lean mass, and adipose tissue, fat mass. That's really useful, particularly in the context of adipose for understanding like how much visceral adipose do you have versus other types of fat. And we know that visceral adipose is probably the most important for metabolic health, to having low visceral adipose. If you go for a bone density scan, what they're going to do is do a more targeted evaluation of bone density in those regions where people tend to get fractures, particularly when they're older, so hips and spine in particular. That's really useful for diagnosing osteopenia or osteoporosis. I think the whole body DEXAs can be useful from a screening perspective to look at bone density. And if you see something there that is concerning, you can go get the more in-depth clinical diagnostic DEXA for bone density.
Great. So for everybody watching who has not done a DEXA, their first one, always go probably full body comp. Look at your T and Z, and then maybe decide if you need a bone
yes,
density.
Unless you are referred to a bone density DEXA because of concerns about osteopenia or osteoporosis. Great. Yeah, what you won't get from that are the information around muscle mass and fat mass.
Yeah. All right, makes sense. So this is actually referring to our first DEXA video, probably about a year ago now. And they asked, did you reach your body comp goals?
So I think, if I remember correctly in that video, I said that I wanted to get down to single digit, like 9.99% body fat. So no is the answer. And I think I showed a DEXA more recently than that, where my weight, this was after I went on testosterone therapy. So when I went on testosterone therapy, since going on testosterone therapy, and we might need to have a longer discussion about whether this is optimal. I'm sure it isn't, but since going on testosterone therapy, I have gained about 20 pounds. Wow. More than half of that is muscle mass, but still a significant amount of fat mass. And my percent body fat has gone up probably from like 11 point something. I haven't done a DEXA in a few months to, I'm guessing 15 to 16% body fat right now. So I did not ever get down to 9.99% body fat. And again, I recognize that single digit body fat is not optimal for health, most likely. That was just sort of a personal, goal, vanity goal, call it what you want. Once in my life, I would like to get down to single percent body fat. I haven't given up on the goal. When I get there, I will be sure to let you all know. Maybe I'll rip my shirt off like the Hulk.
You won't have to tell them; they'll just know. They'll look at you. So, what's your current body weight?
I'm probably around 195. So I was when I was at 11 point something, I was 175.
Yeah. That's fluctuated quite a bit since even the last 2 years of me knowing you.
Yeah. Yeah, I mean, it's interesting. If I go back to 2022, I think that was when I had my first DEXA. I was at 195, but I was at 24% body fat or something like that. So now I'm same body weight, but a pretty significant change in body composition.
10% less, something like that?
Yeah, body fat. Probably, yeah.
Great. Okay, here's an interesting question. So whole body MRI at age 15 and then every decade after that for baseline.
Huh. So I think one thing I would say is I can't think of a compelling medical reason that most people would get a whole body MRI, let's just say below the age of 40. Having said that, obviously, if there's a specific reason for an individual to get it, they should. So I wouldn't necessarily say that there's a good reason to start doing whole body MRI at age 15. Is there a downside? I mean, again, you have to recognize the possibility of false positives. Also, maybe you would detect something, that is abnormal at that age, but rare in some people. I don't think, certainly I wouldn't say that everybody should get a whole body MRI at age 15. If I could go back in time and have whole body MRIs on myself since age 15, I'd love to have that data. So if you want to do it and you can afford it, or your parents are willing to pay for it, and you recognize that there is the chance that you will have a false positive or one or more false positives, that's what you want to do, go for it. I don't see a reason not to do it necessarily.
Yeah, just kind of imagine that, because right now you'd be close to having 5 full MRI scans in front of you over the course of, a 40-year span.
Yeah.
What would you do with that data? Like, how just be kind of useful to have, or other than the whole preventative in terms of cancer screening?
Yeah, it's a good question. I mean, again, I'm a data geek, right?
Yeah.
So I would like to have that data and just see. So the question would be like, what might you detect that would be useful or somehow inform you in a way that would help guide lifestyle modifications, for example. So, I mean, of course, whole body MRI, you can get information about body composition. You can detect early signs of pathology. Again, it's a good question. I don't actually know the data to say, what percentage of people might you find a clinically meaningful outcome from whole body MRI at age 30. I just don't know the answer to that. There's going to be some percentage of people where you would detect something that you could act on very early, but it's probably going to be small. I just don't know the answer to that.
Yeah, makes sense.
Yeah, again, I don't think there's any medically compelling reason to start doing whole body MRI at a young age, unless you have some condition where it warrants that. Having said that, I'd like to have that data for myself.
Yeah, I feel that. So, does time-restricted eating add benefits beyond caloric restriction?
I mean, we've talked about this a few times, and I know I've talked about this quite a bit as well on other people's podcasts. So in my opinion, this is still to be determined. Like, we don't have all of the data to know for sure whether time-restricted eating, and again, just for definitional purposes, we'll say, restricting the window of time each day that you eat to a 12-hour or smaller window, right? I don't think we have any evidence that there are significant health benefits to doing that unless you are also in a caloric deficit and losing weight, and you need to lose weight to get to an optimal body composition. But that doesn't mean that it's impossible, and there's some, hints that there might be some benefits in terms of insulin sensitivity that's independent of calories. My personal take is that it's unlikely you're going to get any significant benefits from time-restricted eating if you're not also in caloric deficit. And I am absolutely confident that time-restricted eating has been way overhyped, and that the people who suggest that it has all sorts of benefits simply don't know the literature very well. Or maybe they don't care. Regardless, I think the way I frame this is, if you think about what you eat, you can think about the composition. So what you eat, you can think about how much you eat, and you can think about when you eat. And I'd put TRE as under the when, as I would also put intermittent fasting. So if you sort of rank those in order of most important, what you eat and how much you eat are really, really important. And when you eat is not very important at all, in my opinion. at least relative to each other. All can have some benefits. Then the last thing I'll say is time-restricted eating is a very useful strategy for some people to avoid overeating. So when you eat can affect how much you eat. And so in that case, if it's a really useful tool for you to avoid overeating, great, do it.
Yep. You still, since we last spoke about this, you haven't done any of it. You eat breakfast first thing in the morning and then you stop eating.
I don't intentionally do time-restricted eating. I have moved to exercising before I eat. So I used to be somebody who would get up, I was hungry, and I ate right away. And I have moved to, usually, my typical morning routine, right, is I get up, I set the coffee maker the night before so that there's coffee ready when we get up, and I have a couple of cups of coffee, go through my email, spend about half an hour getting stuff done. I know I should go outside and sit with my special funky glasses on and do all that stuff. I don't typically do that.
Meditate for 2 hours.
But I sleep pretty well. So, maybe I don't need to reset my circadian rhythm, regardless. And then I go work out. And so I typically don't eat breakfast until, I'm a couple hours into my day, sometimes longer. But I get up at 4:30 in the morning, so it's still pretty early in the morning. So it's maybe, let's say 7 a.m. is when I typically eat something. And then, I typically don't eat anything after dinner, and we usually eat dinner pretty early. So I guess it sort of naturally compresses into a 12-hour window, but I'm not doing it intentionally.
Yeah, mine's almost identical. So, all right. So next question on related to diet, nutrition, and fasting. So this is actually someone emailed this in. I thought it was very interesting. So he said, did you know 82 to 84% of the whey we consume is converted to sugar or body fat, and only 16 to 18% is used to make new protein in our body? This claim is from Gary Brecka, for Perfect Amino on Facebook. This can't be right, considering the source. The claim itself doesn't surprise me, though.
So I'm, first of all, not going to comment on Gary Brecka for a few reasons. Maybe we'll save that for another episode. Okay. And I don't know if that's actually what he said. So I don't want to. So what I will say is this statement is incorrect. I don't know if that's what he actually said or not. If he did say that, then he's wrong. Maybe in some people, if you are, massively overeating, you're going to get some significant fraction converted, but I don't even think then it would be 82 to 84%. So it's just nonsense. Ignore it. Move on.
The hint of truth would be there is gluconeogenesis if you were like in a calorie surplus eating a lot of protein. Some of it might get converted to carb just by getting rid of the nitrogen.
But again, I think this is also where, people who don't really understand biology can get confused. So yes, maybe if you were to consider this through the lens of, do any of the carbons that make up the backbone of the amino acid chain that is the whey protein ever get converted eventually to sugar? All of these metabolic pathways are interconnected, right? That happens, but that's different from the way this is being interpreted, which is that when I eat protein, it gets converted to sugar in my body, and therefore it's just like eating sugar. That's nonsense.
Yeah, absolutely. Great. So I saw this a couple of times. I'm meaning to ask your opinion on it. Do you consider protein bars a supplement? Like David bars, for example, or relatively, we'll say clean protein bars.
No, I don't. They're food. So I wouldn't consider them a supplement per se. But this is sort of semantics, right? Again, is taking a protein powder a supplement? A protein shake a supplement? I guess if you think of those things as supplements, you can call it a supplement. It's not a nutritional supplement in the sense of, something that is not a macronutrient, right? Not caloric, that you're taking because either you're trying to fix a deficiency, so vitamins, for example, something like that, or you're taking because you think that molecule has some bioactive property independent of the caloric component or the macronutrient component. So for that reason, I wouldn't put it in the supplement category.
Not a supplement, but would you categorize it as processed?
Yeah, clearly it's processed food. Of course.
That's always been interesting because it also seems semantics on where do you draw the line between, like, is cheese processed? Like, I know there's Nova classes, which is
I don't think that's the question. It's highly processed food. Yes, of course. I think the question is all highly processed food bad? Yeah. Is all highly processed or ultra processed food equally bad? I think those are the questions we should be asking. I think obviously there are differences in the negative health consequences and implications of different types of ultra processed foods. Again, anybody who wants to say that all ultra processed foods are equally bad for you just simply does not understand biology. It's not the case. I think it's a legitimate question that, let's think about the very best ultra processed protein bar you could possibly make, right? If you could do that, would that be net beneficial or detrimental in the context of the best possible diet you could eat that doesn't include ultra processed foods? I don't think we know the answer to that. So I think it's sort of a silly argument to have at this point. My sort of pragmatic view on this is, if you want to have a good quality protein bar once in a while, have a good quality protein bar once in a while. What does once in a while mean? Is that 1 bar a day? Is that 1 bar a week? Is that 8 bars a day? Again, 8 bars a day is too much. 1 bar a day, I don't know. Yeah. I don't know. I think if you're doing everything else right and that helps you hit your protein goals, great. No big deal. Yeah. Don't sweat it. Yeah, it would be my thoughts. I'm not going to get all worked up if I have a little bit of ultra processed food once in a while. I don't think you should either. But you should not have a diet that is primarily ultra processed food.
And that's because your first order principle is just net calories.
No, I wouldn't say that. Again, if we go back to what you eat, how much you eat, and when you eat, I'd kind of put what you eat and how much you eat is roughly equally important.
Okay.
So I absolutely think that dietary composition is very, very important. Those two things are really important. When you eat is not very important, in my view. So I would certainly not say, as long as you're eating, your calorie goals, you can eat whatever you want. That is bad advice.
Yeah.
So no, I don't think I would necessarily put calorie goal as the most important or the first order consideration. I would consider both of those very carefully together. What I am saying is, you don't have to be perfect. And I personally don't think there's a lot of downside to having a relatively small fraction of your calories in the form of highly processed food, as long as it is made with quality ingredients, right? To the best you can. The real answer is, we don't know. Again, could it be the case that if you could engineer the perfect highly processed diet, and that's all you ate, but it was perfect, that it would actually help you live longer than a Mediterranean diet? Yeah, that's absolutely possible. We don't know. Yeah. So I don't want to demonize any food that's processed just because it's, fashionable to demonize highly processed foods. I don't think that's a very scientific view of the information, and it's really not a useful way to think about it, in my view.
That's helpful. I'm happy we went into the nuance there.
Okay.
So here's a fun one to end on. So you were recently in Ireland, and this person asked, how's the Irish whiskey in Guinness?
So I was in Dublin for the Dublin Longevity Summit, which was a really interesting conference, and we've talked a little bit about that on the podcast. So how's the Irish whiskey in Guinness? I did not have any Irish whiskey in Ireland. I'm first of all not a hard alcohol drinker, never really have been. So I didn't have any Irish whiskey. I did have a couple of pints of Guinness while I was there. It was good. Honestly, though, and my wife and I both felt this way, it wasn't as good as our last visit. And I think that was more like environment and circumstance than anything else. We really liked the Guinness on our last visit. And I think part of that was we have some really good memories of Ireland. I love Ireland. It's a fantastic place to go. One of my favorite memories was a friend of ours, Tom, has a place in East Dunmore, which is kind of at the south part of Ireland. And when we went, we drove all the way around Ireland in about 10 days, ended up in East Dunmore. And he had a bar in his place. So the Guinness there was really good. And then we walked one night up to a local pub, and it was really this cool experience where there were probably 6 or 7 guys, all sorts of ages, mostly older, but there were some young guys there. Each of them had an instrument. And they would just kind of sit around, and one of them would start playing a song and singing, and the rest of the guys would join in, the people who wanted to. It was just a really cool, at least what I would think of as kind of traditional Irish pub experience. And so I think that all contributed to my memories of how the Guinness tasted on that experience. Yeah. We tried to find some traditional Irish music in downtown Dublin where we were staying. We were unsuccessful. So maybe next time I get to Ireland.
Great. That sounds like a lot of fun. So that's everything I have for you today. Yeah, thanks
Great.
for your time.
Thank you. Yeah, it's been fun. And thank you for watching this episode of the Optispan podcast. As always, if you have any comments or questions, please leave them here or go to our website, www.optispan.life/podcast, where you can leave your questions and comments for us. And if you're not yet a subscriber, really want to encourage you to hit that subscribe or follow button below.